Thank you for joining my presentation on the fundamentals of oxygen therapy. My name is Terrence Shenfield, and I've been an education coordinator at a major trauma center in New Jersey for most of my career. At the end of this presentation, you're going to have a good handle on exactly the use or the misuse of oxygen therapy, and you'll understand some basic guidelines for the clinical practice of its use. Today's learning objectives are, I'm going to describe when oxygen therapy is needed, what kind of patients really need oxygen therapy. I'm going to teach you how to assess the need for oxygen therapy by using certain tools. I'm going to describe the precautions and complications associated with oxygen therapy. And most importantly, I'm going to teach you how to select the proper oxygen delivery system based upon the needs of the patient. So you're going to cover some of these objectives, and I got some further objectives on the next slide. Other objectives for this presentation, I'm going to describe how to administer oxygen therapy to adults, children, and infants. I'm going to describe how to identify and correct malfunctions of oxygen delivery systems. I'm going to teach you how to assess and monitor the patient's response to the oxygen therapy. And then I'm going to talk about how to modify the oxygen therapy to the patient based upon the medical condition and as they are progressing through their care. So at the end of this presentation, you're going to really have a good handle on the use of oxygen therapy. So we're going to do a little pre-test. I'm going to test your skills on whether you know how oxygen therapy works. You're not going to be graded on this, but I would appreciate if you could either write down the answer on a piece of paper at home, or you could put the answer in the Q&A here that we're doing a Zoom meeting. So first question, what is hypoxemia? Is it number 1, decreased tissue oxygenation? Is it number 2, increased tissue oxygenation? Is it number 3, low levels of oxygen in the blood? Or number 4, is it high levels of oxygen in the blood? So just again, like I said, put your answer on a piece of paper. We're going to go over these questions a little bit later, or you could put it in the Q&A right now with Zoom. Here's your second question. What is oxygenation? Is it the inhalation and exhalation process of the body? Is it number 2, oxygen being used for the body? Or number 3, is it the delivery of oxygen to the body tissues and cells? So which one is it? 1, 2, or 3? Again, put it on a piece of paper, or you could put it into the Q&A, and we're going to be going over these questions a little bit later. Our next question. Which oxygen delivery system is for high flow oxygen? So is it number 1, a nasal cannula? Is it number 2, a partial rebreather? Is it number 3, a Venturi mask? Or number 4, is it a simple mask? And again, this falls into the same program we did before. You either put it on a piece of paper, or you could put it in the Q&A, and we could go over this a little bit later. So please answer this question. Okay, our final question. Which oxygen delivery system would you use for the lowest flow of oxygen? Would it be number 1, a simple face mask? Would it be number 2, a non-rebreather? Would it be number 3, a nasal cannula? Or would it be number 4, a partial non-rebreather? Again, in the Q&A, you could put an answer, or you could put a piece of paper, answer on a piece of paper, and we're going to be going over this a little bit later, and we're going to go over the details of what's going on with this. So we're going to do some visual exercises here. I'm not going to tell you what the device is, but what does this gentleman have on? What kind of oxygen device does he have on? I know this is very basic, but this is a review that could benefit many people who are just sort of new to the field, as well as those who are not quite used to seeing these different devices. So what is it? Again, put it on a piece of paper, or you can put it in the Q&A, and we're going to get back to that a little bit later. Okay, this young lady has a mask on. What kind of mask is that? Is it a non-rebreather? Is it a partial rebreather? Is it a venti mask? Is it a high flow? What is this system? What kind of system is being put on this patient? Again, put it on a piece of paper or put it in the Q&A, and we're going to go over these details just a little bit later. For all you seasoned respiratory therapists and all you nurses, this particular question deserves a good answer. So, what is this? What kind of device, what kind of oxygen delivery device is this? You notice you got various colors. What's the purpose of those colors? Again, put it in a Q&A, or you could put it in a piece of paper. And again, we're going to go over this. And if you know this stuff, which I'm sure you do, this is just a quick review for those who don't. So be a little kind and patient with the rest of the group. There are many goals for oxygen therapy, but the main categories are to maintain adequate tissue oxygenation and to minimize cardiopulmonary work. So let's talk about certain circumstances that would lead to inadequate tissue oxygenation. If you have pneumonia, if you have asthma, if you have emphysema, if you have ARDS, if you have idiopathic lung disease, all of these can result in inadequate tissue oxygenation, so you need supplemental oxygen. Then there are conditions where the heart is not pumping correctly. If your heart is not pumping correctly due to congestive heart failure or other kind of cardiomyopathies, you need some supplemental oxygen. Some of the clinical objectives for oxygen therapy is to address acute hypoxemia. Hypoxemia could be recognized by physical signs as well as getting a pulse oximetry or a blood gas. Also, if you happen to have chronic hypoxemia, oxygen therapy will relieve it. And also, you could decrease the workload of the heart by giving additional oxygen. So these are some of the overarching goals of oxygen therapy, and there are many different medical conditions that could benefit from it. So the point is, recognize what the condition is and then use some kind of supplemental oxygen for these patients. So how do you quantify the need for oxygen therapy? And documented hypoxemia is evidenced by a PaO2 of less than 60 millimeters of mercury or an SaO2 less than 90% on room air. If you see any of these conditions, the patient does need some kind of supplemental oxygen. Also, there are acute care situations in which hypoxemia is suspected. A lot of times patients who have severe trauma can end up getting be hypoxic. Someone with an acute myocardial infarction or any kind of heart condition can have decreased saturations. Also, someone who's getting surgery. A lot of times these patients are given sedation, and on post-anesthesia recovery, they hypoventilate and they don't have good oxygenation status. So these are some of the categories where oxygen therapy is indicated, and you could objectively measure that by a blood gas or a pulse oximetry, and you could look at certain values like the PaO2 less than 60. So these are some of the indications, some of the signs for assessing these patients. Let's talk about some of the precautions of oxygen therapy. Studies have shown that if patients who receive an FiO2 greater than 50% can have some complications. These complications could be absorption atelectasis, oxygen toxicity, and depression of ciliary function. So let me get a little bit more detail. Absorption atelectasis is basically collapsed alveolar as a result of the nitrogen being washed out, and this causes air trapping, and this also causes atelectasis. So if you have too much oxygen going into the alveolar space, you could wipe out all the nitrogen in there, and then the airway is predisposed to collapsing and air trapping. In regard to oxygen toxicity, if you have someone receiving 100% oxygen for 24 to 48 hours, they can get two likely conditions. One can impact the central nervous system, and the other one can impact the pulmonary system. For example, with people with CNS effect, they could get tremors, they could get shaking, they could get headaches, while the pulmonary effects are coughing, shortness of breath, and things like that, and even bleeding. So the point is, really don't put someone on 100% oxygen for more than 24 hours or 48 hours. Definitely, titrate it back. Also, studies have shown that patients who receive high levels of oxygen have a depression of ciliary function. And we all know what the ciliary function is. Basically, these are little hair-like fibers on our lung that sort of mobilize particles that we could cough out. And if you have a depression of that, that means you could be predisposed to getting pneumonia. So there's, oxygen is a good thing, but you got to watch and how long you give it and what kind of level you have it on. Now, if you have a patient on mechanical ventilation, you could always utilize PEEP. But some people who are not on mechanical ventilation, you got to really sort of watch how long you keep them on 100% oxygen or anything greater than 50% for a prolonged period of time for these particular cases. Let's further the conversation about the contraindications of oxygen therapy. And I'm going to talk about 3 different examples. One is called carbon dioxide narcosis. The other one is called retinopathy of prematurity with the neonates. And the other one, I'm going to further the conversation about oxygen toxicity. So let's start with the carbon dioxide narcosis. Excessive CO2 in the bloodstream will lead to a depressed level of consciousness. If you have too much CO2, you will actually stop breathing and you'll have, you could die. What kind of patients are predisposed to this? COPDers. COPDers, when you give them high levels of FiO2 or high levels of oxygen therapy, it could suppress their respiratory cycle. And what happens is their CO2 climbs up and they suffer from carbon dioxide narcosis, which could lead to unconsciousness and death. So the idea is don't give high levels of FiO2 to COPDs because this can happen. The second concern is retinopathy of prematurity. And we all know that is a condition of the neonates. And why does that happen? Basically, when babies are born, they do not have a very good antioxidant system. And so you're saying, why am I talking about antioxidants? Remember, when you give oxygen therapy, high levels of oxygen therapy, a byproduct of the metabolism of oxygen is free radicals. And in particular, you're talking about free radicals that could do harm to the patient. So because babies don't have, or at least have an immature antioxidant system to fight off those free radicals, they could suffer from what is known as retinopathy of prematurity. So you don't want to give high levels of oxygen to babies because they don't have enough antioxidants, and the side product to that is retinopathy of prematurity. And actually, oxygen promotes neovascularization, which means that it creates new vessels in the eyes, which cause edema, which cause blindness. So you really want to watch. And finally, we were talking a little bit about oxygen toxicity before. And again, we're talking about free radicals. When oxygen is metabolized, superoxide anions are produced. And these superoxide anions are free radicals. And they could do some kind of harm to the body. Best, they can impact your proteins, they can impact your DNA, they can impact so many different parts of the cell, especially the cell wall and everything like going along with that. So again, oxygen toxicity impacts the free radicals in the body because the oxygen is metabolized, and then our antibodies, not antibodies, our free radicals are not produced enough to fight off these superoxide anions, resulting in tissue damage. So these are the major contraindications of oxygen therapy. Oxygen therapy could do wonders on one side, but it's a double-edged sword, so you got to know what you're doing with it. So what kind of conditions benefit from oxygen therapy? And you could divide those into two different groups. One would be a chronic group, and the other one could be an acute group. Now, in regard to chronic disorders that you would need oxygen therapy, COPD is at the top of the list. A lot of patients who have COPD have a hard time oxygenating, and as a result need supplemental oxygen. What kind of supplemental oxygen? A simple nasal cannula at 1 liter per minute may just make all the difference in the world. Also, patients with cystic fibrosis. Cystic fibrosis patients, especially end stage, have pulmonary disorders and what they have bacterial infections, and as a result, they need oxygen therapy to get through that. Also, patients with pulmonary fibrosis, because of the scarring of the lung, they need oxygen therapy. ILD, that's another form of fibrosis, which again needs oxygen therapy. Now we have that's the chronic side. Let's talk about the acute side. There are many acute disorders that really need oxygen therapy. For example, if someone is septic, they need definitely oxygen therapy because of tissue oxygenation. Major trauma, if anyone has a chest contusion or a flailed chest or a pulmonary contusion, all of those patients could benefit from oxygen therapy. Now, in regard to cardiac arrest, a lot of times these patients are given oxygen therapy to recuperate because the heart needs oxygen. Also, patients who have carbon monoxide poisoning or cyanide poisoning, they benefit from oxygen therapy. And then they have what is known as transfusion-related acute lung injury. And transfusion-related acute lung injury occurs when a patient gets a transfusion and then they get almost like ARDS symptoms, and as a result, they can benefit from oxygen therapy. So when you think about oxygen therapy, you have your chronic disorders and you have your acute disorders. And you should understand the application of different type of oxygen devices with each type of patient. And we're going to get more into that as we go along. So let's get down to basics. The air we breathe, what we're breathing right now, typically consists of 21% oxygen, 79% nitrogen, and then there are other trace gases in the air. For example, there's carbon dioxide, which is great for plants. There's argon, there's neon, there's helium, there's methane, there's hydrogen, and there's a host of other different trace elements of gases in room air. Now, the question is, our bodies use nitrogen, and how do we get this nitrogen in our body? We get it through the food we eat, and we get it through the air we breathe. 79% of the air we breathe is nitrogen. Why is nitrogen important? Nitrogen is important because think about protein, think about DNA, think about RNA. The building blocks of our body contain nitrogen. So what's the benefit of oxygen? What role does oxygen play? A very important role. Think about ATP. You all have heard of ATP as the fuel that keeps us alive. When we eat carbohydrates and we eat proteins and we eat fats and it's metabolized in our body with oxygen, we produce ATP, which is energy. Our bodies could not run without this energy. So this is some of the basic understanding of the air we breathe, and we need every part of it to keep alive. Let's talk about the basic physiology of oxygen therapy. There are certain values that we're going to get a little bit more detail as we go along. We're going to be talking about PO2, SaO2, CaO2. They all have O2, but they are different. We're going to also be talking about PaO2, which is a sensitive and non-specific indicator of the lungs' ability to exchange gases. Then we're going to be talking about FiO2. FiO2 is a concentration of oxygen in a gas mixture. Remember that room air has 21% oxygen, 21% FiO2. Normal PaO2 decreases with age. So the older we get, the normal PaO2 level will decrease. Normal PaO2 with a normal healthy adult is anywhere from 80 to 100 millimeters of mercury. And most importantly, the body does not store oxygen, so we need a constant source of oxygen coming in our body. So I'm going to break these concepts down a little further on the next couple of slides. This may be a review for you respiratory therapists and nurses, but what exactly is PaO2? PaO2 stands for partial pressure of oxygen. And basically, this is the partial pressure of oxygen in the blood, and it's determined by the amount of oxygen we inhale, the amount of CO2 that's in the alveoli, and also the architecture of the lungs. So any of those variables could change the PaO2. Normal values of PaO2 are 75 to 80 millimeters of mercury, and this can be obtained via a blood gas. A blood gas is your tool to determine your PaO2. Let's now turn our attention to SaO2. SaO2 is not SpO2, which can be obtained through pulse oximetry. SaO2 is the percentage of available binding sites on the hemoglobin molecule that is bound with oxygen in arterial blood. Basically, oxygen is transported in the blood in two ways. It's either dissolved in the plasma, which is called the PO2, or it can be bound to hemoglobin, which is called the SaO2. About 97% of the oxygen bound in hemoglobin, so most of the blood and oxygen is binded with the hemoglobin molecule, which is about 97%, where the 3% is dissolved in the plasma. There's a term called the O2 dissociation curve. We're not going to get much into that because that could be a whole lecture in itself. But I just wanted you to know that SaO2 is unaffected by the content of hemoglobin, so anemia doesn't affect SaO2. So think of SaO2 as the percentage of available binding sites on hemoglobin molecule that is bound with oxygen in the arterial blood. SaO2, not SpO2. Another common term we use is called CaO2. CaO2 is the amount of oxygen bound to hemoglobin and well as unbound to hemoglobin. So it's a total amount of oxygen in the blood. SaO2 doesn't really measure this, PaO2 doesn't measure this, but CaO2 really does a good job of measuring this. When you think about CaO2, you could think about tissue oxygenation. You know, does the tissue in the body get oxygen? Units of CO2 are in milliliters of oxygen per 100 milliliters of blood. For those who are geeks and like the formula, I'm sure you all remember the formula on the right. Hemoglobin times 1.34 times SaO2 divided by 100 plus the fraction of unbound hemoglobin. So that's the typical equation. The value of this is tissue oxygenation. It's the total amount of oxygen in the blood, and it's not impacted just, it's not just by hemoglobin, it's also in the plasma. SpO2 is measured via pulse oximetry. A pulse ox is one of the most valuable devices you can have in determining oxygen saturation. Basically, it's a non-invasive method. You just put it on your finger, and as a result of some rays going into your blood and picking up spectrums of light, they could determine the saturation of your oxygen. Basically, it is a percentage of the oxygen bound to hemoglobin and the total amount of hemoglobin in the blood, so it has a dual factor there. It's good for peripheral oxygen saturation, so you could put it on your finger, you could put it on your toe, you could put it on your ear, and you get a good value. It's an estimate of arterial oxygen saturation. It's not exactly, it's typically higher than SaO2, but it's typically, it's a good indicator. Sometimes it's not very useful for a couple of reasons. Number one, if someone has CO2 poisoning, the pulse ox cannot differentiate between oxyhemoglobin and carboxyhemoglobin. As a result, you might get a great value on your pulse ox for the patient. You think they're great, but it's actually carboxyhemoglobin they're measuring, so it's not very good at all. You need a blood gas with that. Also, SpO2 does decrease in age. As we get older, a normal value for SpO2 will decrease. So if you have someone who's 75 years old and they're satting at 91%, that could be very normal for them. So it's a very valuable tool. We use it all the time, and that is SpO2. So let me cover some tidbits of oxygen therapy. Number one, supplemental oxygen is a drug. So anytime you give a oxygen therapy to a patient, you need an order. It is considered a drug. And anything above 21%, 24%, 30%, 40%, whatever you have, that needs an order from a physician. So think about this. Oxygen is a drug when you administer it to a patient. Sometimes patients who have a reduced PaO2, you cannot really link a disease process to it. In other words, you could not definitively to say that this patient has COPD or they have emphysema or they have pneumonia, because it's really non-specific. You need to do further tests. And another thing I just wanted you to know about, you cannot use an A to A gradient, PaO2 to PO2 difference, which is commonly called the A to A gradient, to rule out pulmonary embolism. Many patients who have pulmonary embolism have a normal A to A gradient, so you really can't do it. And just for a little information, a normal A to A gradient for a young adult non-smoker is around 5 to 10 millimeters of mercury. Also, if you give a given flow of oxygen via a nasal cannula, you really can't say you're given a specific FiO2. You could guesstimate, like if you give someone 3 liters of oxygen, you could guesstimate that might be a certain amount of FiO2. But at this point, you really can't do it because so much air is being entrained into the nares, and you really can't determine exactly the FiO2 being delivered. And the same thing goes with face masks. You know, just because you put someone on a non-rebreather doesn't mean that they're getting 100% oxygen. So you really got to keep these kind of facts in mind. Oxygen is a drug. It needs a physician's order. And if you have someone with a pulmonary embolism and you're looking at the A to A gradient, you cannot really use it because you could have a normal A to A gradient. Also, when you give a certain liter flow of oxygen via nasal cannula or simple mask or whatever, you can't really calculate how much FiO2 they're getting because of entrainment. And also, any patient who receives a nasal cannula of 4 liters or less does not need humidity. So it's typically when you have 5 liters of oxygen nasal cannula, you need some kind of humidification because it could dry out the nares. So these are some tidbits, and I just threw this out there for your information. So let's get into the nitty-gritty of oxygen delivery devices. There are various systems, and they could be broken down into 3 main categories. One would be considered a low-flow system. The other one could be considered a reservoir system, and the other one would be a high-flow system. In the low-flow systems, you have your nasal cannulas, you have your simple mask. In the reservoir systems, you have your non-rebreather, your partial non-rebreather. Also, in your high-flow system, your high-flow nasal cannula. We're not going to get much into the high-flow nasal cannula system because I got a whole PowerPoint on that. But if you wanted to talk about when would you use one type of device, what are the features of this device, it all depends on the clinical condition that the patient's in. What do you need to offer? If someone needs a simple nasal cannula, obviously they're not that sick, or someone with COPD or chronic COPD, you know, you would use low flow systems. If someone was in demand, needed higher levels of oxygen therapy, a reservoir system might be best. And then finally, we have the high flow systems. Like I said before, I'm not going to get much into it. So based on the clinical condition of the patient, based on the device that we use, it all depends. And sometimes, these devices could deliver various levels of FiO2. So, low flow systems are limited. Reservoir systems can give you high levels of FiO2, and high flow systems can actually give you high levels of FiO2. So you pick the right device based upon the condition of the patient. And we're going to go more into this on future slides about each type of system, the low flow system, the reservoir system, when you should use it, and the characteristics of each type. So I got to start this lecture on FiO2 delivery based on flow rate. Suppose we are using a low flow system such as a nasal cannula or a simple mask. If someone breathes in room air, they're breathing in 21% FiO2. But as soon as you introduce oxygen, you start increasing the FiO2 based on the flow rate. So the ratio of FiO2 and flow rate is very important. As you increase the flow rate of the oxygen, you increase the concentration of oxygen, the FiO2. So for example, if you have a simple nasal cannula on and you put 1 liter per minute, your FiO2 delivery will be approximately 24%. Remember, it's not an exact number because of the entrainment of air. If you give 2 liters per minute, it'll go up to about 28%. If you give 3 liters per minute, it'll go up to 32%. You notice that the 1 liter goes up by 3 liters per minute. 3 FiO2 goes up by 3 from 21 to 24, but as you increase it, it goes up by 4. So remember that flow rate of oxygen impacts FiO2. Room air, 21%. 1 liter, 24% FiO2. 2 liters, 28% FiO2. 3 liters, 32% FiO2. What happens when you get up to 5 liters at 40%? Are you given exactly 40%? No, it's variable. One of your concerns here, though, is that the flow rate is so high at 5 liters per minute that you need to introduce humidification in the system. Anything less than 4 liters per minute, you don't have to worry about. Anything 5 and greater, you need to add humidification or you're going to dry out the nares and create nosebleeds. So this is a simple chart, and I just wanted you to understand the concept between flow rate and FiO2. The lower the flow, the lower the FiO2. Is it an exact number? No, because you entrain air, but it's approximately those values. So based on the clinical condition of the patient, you could give that flow rate as needed. All right, so I needed to start you off with this so you get a basic understanding. So let's talk about some of the basic equipment for delivery of oxygen. And in particular, we'll be talking about the nasal cannula, the simple mask, and the Venturi mask. There are other masks called non-rebreather mask and partial non-rebreather. We'll get back into that a little bit later. Let's first start off with the nasal cannula. A nasal cannula is a simple plastic device that fits on the nose. The delivery of liter flow is anywhere from 1 to 6 liters. Remember, if you have 5 liters or above, you really need to do some kind of humidification. And remember, room air is 21%. So when you deliver 1 liter per minute, you go up to 24%. And every liter after that goes up approximately 4%. So the first one is up by 3%, and then every liter after that is up by 4%. FiO2 decreases as minute ventilation increases. So what happens is, as you breathe quicker, you entrain more air, and that's why there's a decrease in FiO2. Now let's talk about simple masks. Simple masks are simple plastic masks with perforated openings on and little mask holes for them for exhalation. And they typically start with a liter flow of anywhere from 5 to 8 liters per minute. The FiO2 being delivered with these simple masks is anywhere from 35 to 55%. And again, based on the liter flow, the higher the liter flow, the greater the oxygen content. You need a minimum of 5 liters per minute flow to blow out the CO2 in the mask, because when the patient exhales, the CO2 stays in that mask area a little bit. It doesn't get all fully exhaled, and it can rebreathe that CO2. So to flush it out, you really need to have a minimum flow of 5 liters per minute. Then finally, we get the Venturi mask. The Venturi mask, there are various types that work, and some of them have like these different color adapters, like yellow, green, purple, blue, and so on. And each of them represents a certain FiO2. The FiO2 characteristics of this system is anywhere from 24 to 50%. And based upon the adapter you use and based upon the flow, you will have a FiO2, and it varies by manufacturers. There are many different companies who offer Venturi masks. Venturi masks are good if you want to give a higher level of FiO2 and if you want to really control the FiO2 being delivered to the patient. So in regard to the hierarchy of oxygen therapy, nasal cannula is the lowest, followed by a simple mask, followed by a Venturi mask, followed by a non-rebreather mask. And then you can get into high flow oxygen systems, but I'm not really talking much about that during this presentation because that's a whole lecture in itself. So let's talk about low flow systems. And the 2 low flow systems that come to mind is the nasal cannula, which is the top image, and a simple mask, which is the bottom image. Both of those can deliver an FiO2 anywhere from 24% to 40%. They also can be used with various flow rates, anywhere from 1/4 liter per minute to 8 liters per minute. The FiO2, what is actually being delivered to the patient, varies based upon entrainment of air that's in the room. So in other words, if you have a simple mask and the mask is loosely fitted, you're going to get a variable FiO2 delivery because entrainment of air coming into the room. Typically, these devices are well tolerated. The only thing I would say that if you have a flow of greater than 4 liters per minute, you might want to offer some kind of humidification so it doesn't dry out the nares. These are the most simplest type of devices. They are low flow systems. They deliver FiO2 up to 40%. The flow rate will go a maximum of about 8 liters per minute. And typically they're well tolerated by patients. And remember, if you're using a flow greater than 5 liters per minute, 5 liters and above, you want to offer some kind of humidification with these devices. So this is the Venturi mask. I wanted to give you a picture of it. And remember, I was telling you that the FiO2 delivery can be anywhere from 24 to 50%, and that could be based upon the adapter you use. You see on the bottom, you have all those adapters, the blue one, the white one, the red one, the orange one, the green one, etc. Every one of them correspond to a different FiO2. So if you put that, you see the top picture of the girl with the mask on and she has a little green adapter, that could be, say, basically 32% FiO2. And if she put a yellow one, it could go to 28%. If she puts the red one on, it could be 46%. So based upon the need of the patient, you could adapt the FiO2 settings based upon the adapter. And that's a Venti mask. And, one mask works perfectly, and you could actually adapt and titrate up and down the FiO2 delivery, and then you could look at the sats of the patient. You could at the pulse oximetry and see if they're satting properly. And so this is your basic Venturi mask. So let's get into the final mask for the day, the non-rebreather or the partial rebreather. Basically, this is a mask that has a reservoir system. That reservoir system actually holds fresh oxygen in it, so when the patient inhales and exhales, they always get fresh supply of oxygen. Typically, the liter flow rate is anywhere from 10 to 15 liters per minute, and it could deliver an FiO2 anywhere from 60 to 80% or even higher. Again, the tighter the mask, the more level of FiO2. This is a great mask for patients who are really, like someone with CO2 retention. No, I'm sorry to take that. Someone with carbon monoxide poisoning can benefit from this type of mask. You put them on 100% FiO2 and you put them a high liter flow at 10 to 15 liters. They have the reservoir bag. I wanted to point out what's the difference between a non-rebreather and a partial rebreather. And I wanted to show you these two little ports. You see these two little ports right here? These are little one-way valve adapters, right? So when they are on the mask, this is considered a non-rebreather. If you want to make this a partial rebreather, all you got to do is remove one of those little plastic inserts, and what happens is you could entrain air. Obviously, a non-rebreather delivers higher levels of FiO2 than a partial non-rebreather. So that's the difference between the systems, and this mask is commonly used in the emergency room, and we've seen patients, even with the COVID patients who are really going bad, we would put them on this. Obviously, high-flow nasal cannula has taken the place of this type of mask, but like I told you before, I'm not giving a lecture today on high-flow nasal cannula. So when monitoring a patient who's on oxygen therapy or a patient who potentially needs oxygen therapy, there are some really good tools you could use. Number one would be a physical examination. There are some physical signs you could look for, and I'm going to get into that in the next couple of slides. Another great tool is pulse oximetry. Pulse oximetry is a non-invasive method. You just snip it on the finger, and you got a great idea what their SATs are. And finally, the best way, but you really don't want to do this because this is an invasive method unless you're in an ICU, is a blood gas. And a blood gas will give you more than just oxygen status. It'll give you your pH, it'll give you PCO2, it'll give you PO2, it'll give you bicarb, and so on and so on. So I'm going to go over a little bit more details about each of these modalities as we go on to the next couple of slides. So what are some of the physical signs of hypoxemia? Hypoxemia means that the patient has low levels of oxygen. And some of the telltale signs that you could see is a change in color. Their lips could be blue, their fingertips could be blue, the skin color could be very dusty and blue. They could be confused, they could be coughing, they could either have a tachycardia or a bradycardia, they could have rapid breathing, they could be short of breath, they also could be sweating. So these are some of the physical signs of hypoxemia, and you should keep an eye on that. Chronic hypoxemia results in clubbing of the fingers. Many times patients who are COPDers get clubbing of the fingers. Patients with, what is that called? Different types of disorders, chronic disorders that have hypoxemia, end up having some physical signs, and these are the physical signs involved with hypoxemia. Another good way of measuring the oxygen content of a patient in a hospital setting is the use of a pulse oximetry. Pulse oximetry is used throughout every ICU, it's used in every step down, it's used everywhere. Even at the bedside, the floor bedside, people use it. And people have these at home. This is a great way of monitoring your oxygen saturation as well as your heart rate. It's a simple device that goes on your finger, and basically it could tell you the percentage of hemoglobin bound in your arterial blood. But actually it's peripheral blood, so it's a peripheral system of measuring your oxygen level. And remember, as someone is sick, if someone has a pneumonia, their SATs will go down. And if someone has any kind of hypoventilation because of, say, sedation or anesthesia, their SATs will go down. So it's a great tool to use. As you know, as I mentioned earlier, people who get older their pulse oximetry values will get less. So what may be normal for someone who's 25 years old may not be the same value for someone who's 75 years old. You can expect that if a 75-year-old has a pulse oximetry of 91, 92%, they're fine, so the point is this: a pulse oximetry is a non-invasive device. It's great at measuring oxygen levels, and it's something you could do really handy, and you could trend it too. A lot of times they use pulse oximetry for patients at night when they go to sleep, and to see if they become hypoxic during the night because of obstructive sleep apnea. So it's a very good tool to have. One of the best ways of determining the oxygenation status of a patient is to get an arterial blood gas. An arterial blood gas is sampled from the artery. It's typically drawn from the radial artery, as you can see with the image on the left, and then they run it through a ABG device that can determine different levels. Now, I know this particular lecture, we're talking about oxygenation, but some of the normal values you're looking for ABG is a pH between 7.35 and 7.45. You're looking for a PCO2 of 35 to 45. You're looking for a PO2 of 75 to 100. And then you're looking at your bicarb of 22 to 26. And then you're looking for your O2 sat to be greater than 95%. So this is one of the best tests you could possibly do, but it is painful, and typically you could do a blood gas and then do some, set up some pulse oximetry to sort of monitor the patient over time. You don't have to do a blood gas every time you want to see what their PO2 is. But this is one of the best ways of determining the blood-based analysis of what's going on with the patient, and you can look at more than just oxygenation status. So as I was mentioning throughout this presentation, there are some complications of oxygen therapy. Number one is oxygen toxicity. Oxygen toxicity occurs when you give 100% oxygen for 24 to 48 hours, and this most likely may occur on a ventilator. What happens is oxygen toxicity results in either CNS problems, such as tremors, headache, or it could also impact the lungs, coughing, bleeding, and so on. So the idea is not to use too much oxygen on a patient, for an extended period of time. The reason for this is that oxygen creates free radicals, and our bodies don't produce enough antioxidants to fight it off. So when you give someone 100% pure oxygen, there's a constant influx of free radicals being generated, and this causes all these problems. Also, if you're a COPD patient, you don't want to give 100% oxygen because it could depress the ventilation. So in other words, their CO2 can climb, they could eventually become unconscious and not breathe at all. Retinopathy with prematurity, that's a problem with children. Again, it falls down into the fact that they don't have antioxidants to fight off the free radicals. So if you give too much oxygen to the preemies or the newborns, they end up getting all this inflammation in the eyes. They get neovascularization, where new vessels grow, and this will cause edema, and again, this causes blindness. And then the final problem with oxygen therapy is absorption atelectasis. When you give 100% oxygen, you blow off the nitrogen in the lung, and this causes collapsing of the airway, and this is what is known as absorption atelectasis. So keep these things in mind. Oxygen can be very good, but it could be very harmful at the same time. So as I was mentioning earlier about oxygen toxicity, it primarily impacts the lungs and the CNS system. And the problem with that is long exposure to high FiO2. From the CNS point of view, it could form tremors, twitching, convulsions, and from the lungs, it could cause uncontrollable coughing, bleeding of the lungs, dyspnea, and rales. So you really got to watch exactly what you're doing with the use of oxygen, especially in regard to oxygen toxicity. So how much oxygen is safe? How much oxygen can you use? If you're going to use 100%, try not to use it for more than 12 hours. If you're going to use 80%, do it for 24 hours, and 60%, not more than 36 hours. The goal is to titrate the oxygen down. Now, if you happen to be lucky, I take that back. If someone happens to be on mechanical ventilation and you have the ability to titrate the FiO2, you also have the ability to titrate the PEEP. So just remember that if someone's on 100% FiO2 on a ventilator, you don't want to have a PEEP of 5 or 8. You may want to go up to 12. And you may want to use the odds-net protocol for this, for titrating the FiO2. So the idea is to use the lowest possible FiO2 to get an adequate blood gas and to get adequate SATs. And adequate SATs can be anything above 90%. You don't have to be 99%. So remember this, because this is what can prevent oxygen toxicity. I just wanted to give you some ideas where oxygen is beneficial. And this is anywhere from 70 to 100%. If you're doing a resuscitation, the heart needs oxygen, the brain needs oxygen. So yes, you could use 70 to 100% during that time. Any time of acute cardiopulmonary instability, if the patient goes Brady or something like that, you can really use oxygen at higher levels. If you're transporting a patient and they are critically ill, again, you could use higher levels of oxygen for a short period of time. So you can use higher levels, but try to use it for a short period of time, and also try to use it in these kind of conditions. I want to recap some of the earlier slides I did. For example, nasal cannula. 1 liter is 24%, 2 liters 28%, 3 liters 32%, 4 liters 36%. When you get into 5 and 6, you get an increase in FiO2, but you also have the ability to add humidification at it. So these are some of the quick guidelines for nasal cannula as a recap. Some other pearls of wisdom are low flow devices are open to air. So note what that means is, if even though you're dialing in 3 liters, 4 liters, you got to remember that you're entraining room air into that, which is 21%. So you really can't guarantee exactly what kind of FiO2 you're getting. Also, remember, if you use anything above 4 liters per minute, you need to add humidification to prevent the drying of the nasal mucosa. Also, oxygen doesn't change ventilation. In other words, sometimes you might be given oxygen to improve the SATs, but if they're hypoventilating and they're not getting enough, not blowing off enough CO2, you might want to consider a BiPAP. So just remember, improving oxygenation doesn't equate to improving ventilation, and you got to look at the PCO2 in that regard. So let's go over the pretest. I asked you some questions at the beginning, and I'm sure during this presentation you gained the knowledge you need. For example, what is hypoxemia? Is it number 1, decreased tissue oxygenation? Is it number 2, increased tissue oxygenation? Number 3, low levels of oxygen in the blood? Or number 4, high levels of oxygen in the blood? And the answer is number 3, low levels of oxygen in the blood. And if you got that right, give yourself a mark. Here's our second question. What is oxygenation? Is it number 1, inhalation and exhalation process of the body? Number 2, oxygen being used for the body? Or number 3, the delivery of oxygen to the body, tissues, and cells? Which one is it? 1, 2, 3. And the answer is, of course, number 3. It's the delivery of oxygen to body, tissues, and cell. Again, give yourself a good mark. Our third question. Which oxygen delivery system is a high-flow oxygen? Is it a number 1, a nasal cannula? Is it number 2, a partial non-rebreather? Is it number 3, a Venturi mask? Or number 4, is it a simple mask? Which one of these would be considered a high-flow system? And the answer is a Venturi mask. That is a high-flow oxygen device, and that was, we talked about that a little bit earlier. Our last question, which oxygen delivery system would you use for the lowest flow of oxygen? Would it be number 1, a simple face mask, number 2, a non-rebreather, number 3, a nasal cannula, or number 4, a partial non-rebreather? And the simple answer is nasal cannula. That is a lowest flow of oxygen delivery device. You could actually give up to a ½ liter or 1 liter of flow with a nasal cannula, and especially with a COPD patients. You guys did great. Well, we're finally here. This is our summary slide. I want to thank you for joining this presentation. I want you to know some key points. Know how to use oxygen. It's a drug, and you don't want to use too much oxygen because of toxicity. Know your devices and their limitations. Certain devices cannot deliver 100% FiO2. They can't even deliver 40% FiO2. So learn that each particular device you use has limitations and it has uses. Number 3, always monitor your patient. You know, just because you put something on a patient, a nasal cannula or a non-rebreather or a venti mask, whatever you decide to do, you should be doing some pulse oximetry. You should be monitoring. You should look for physical signs of hypoxemia, and you should always look at the patient. Also, know how to escalate the care. For example, if you have someone on a nasal cannula and they're satting at 88, what do? You might want to bump it up to a simple mask or a venti mask. Also, know the contraindications of oxygen therapy. Oxygen toxicity is a real problem, and you should really understand exactly how to go about it. I want to thank you for joining this presentation. These are some good references if you wanted to do a little bit more exploring about oxygen therapy. I know I toned this down to some basic oxygen therapy, but I'm trying to reach a larger audience of respiratory therapists who are sort of new to the field, as well as nurses. And, you know, the point is we want to do good patient care, and we want to give devices that can work for them. So I want to thank you, and you have a great day.